I'm chairing today. I'm Professor Sally Theobald, Professor in Social Science and International Health. I'm also the UKRI FCDO Gender Senior Research Fellow, but I'm very much wearing my LSTM hat today. And this panel is a sister panel for the Health Systems Resilience panel yesterday, sitting here, and also takes forward the work of the Health Systems Resilience Institute that was launched yesterday. Hurrah! So, we've got an exciting range of people and perspectives, and we're synthesizing work across a number of different programs and projects with a real focus on equity at the core of global health. Sushil said it yesterday in the plenary session. Jeremy Farrar also talked about equity at the core. We can see it in the beautiful visual minutes from Claire and Holly over there, equity at the core. And we'll be talking about syndemics and having a framing around syndemics, which unites the presentations you'll hear. And we'll also be talking about many forward-looking issues, including those that were introduced in the opening plenary around community engagement, patient advocates, and ethics. So we're going to have 4 10-minute presentations. We're going to keep the questions to the end of those. So at the end of the presentations, I'll invite all our presenters up here to have some questions. And then we've got our keynote to follow. So without further ado, I'd like to welcome Laura Dean, who's a reader at Liverpool School of Tropical Medicine, and she's co-presenting with Abu Conteh, who is a senior researcher at the Leone Urban Research Centre, and he's also a PhD student at LSTM. So thanks, Laura, and thank you for giving us an overview of the syndemics model that the different presentations will link to. Welcome.
Morning, everybody, and thank you for being here on day 3 promptly. It's always nice to have a fuller room. So in the next few minutes, I'm going to share with you some reflections from a collection of projects and collaborative endeavours linked to the Mental Health, Inclusion, Neglected Tropical Disease and Disability Research Group at LSTM, or MIND for short. But as we move through the presentations this morning, I would like you to hold one important question in your mind and think critically about the health systems that we work within, for and utilise, and consider if they're really still fit for purpose. Looking back over the past 125 years and even further, and reflected in the historical roots of institutions like LSTM, we often see health systems that are designed to respond to the role of the sick, with biomedical dominance continuing to shape how we respond to disease and illness. We've considered less the agency and utility that individuals have in being able to support their own health and well-being, and the forms of scientific knowledge that they can contribute towards shaping health systems reform. As we look to the next 125 years and the many great challenges that we've been facing and will continue to face, including climate change, urbanisation, and ongoing changes in population dynamics, I would argue that it's time for health systems evolution. Such health systems evolution is particularly critical to manage the clustering of these issues that so disproportionately affect some of the world's most marginalised individuals in our society, irrespective of where they live in the world. For example, take people with disability, including those with mental health conditions who we've heard notably little about in this conference to date. People with disability are more likely to die in extreme weather events due to insufficient protection. They're 30% more likely to live in areas with environmental risks. The prevalence of diabetes is 3 times higher than in the general population, and the prevalence of cardiovascular disease double. And people with disability are more frequently at risk of infectious diseases of poverty. For example, the prevalence of HIV is twice as high in some settings than compared to the general population. These are just some examples of how illness or disease can cluster for specific populations, be they categorised by geographic location or shared social positions or identities. The COVID-19 pandemic made popular the term syndemics, And as a social scientist, it was nice to see what we often see as a complex term made popular in the mainstream press. Put simply, syndemic framings help us think about how the clustering of disease and ill health are shaped by mutually reinforcing biological, environmental, and sociological conditions that can lead to poor health outcomes. Frequently, these are for marginalised or disadvantaged populations who face multiple forms of simultaneous syndemic suffering. Health systems evolution becomes essential to shaping person-centred responses to the clustering of these diseases and illness, and are critical to shaping the agenda for health equity. But what does this look like from a systems perspective? Let me share an example that's adapted from research completed through the Countdown and Redress programme hosted here at LSTM that have thought about how systems can respond to the syndemic clustering of disease. And in our particular case, we were thinking about neglected tropical diseases and mental health conditions. Starting from the top, right, left, depending on how you're looking at the figure. Systems have to be able to identify the pathophysiology of co-occurring conditions and respond appropriately. But most critically, they have to think about the social, psychological interactions that may be shaping the clustering of these conditions, even where biomedical evidence is unknown. They have to be able to consider how persons affected experience specific health conditions and structure responses accordingly. For example, we know from much research into neglected tropical diseases and mental health conditions that many people experience similar physical and emotional responses within their illness trajectory. Listening to their narratives and experiences can support us to design user-informed approaches and ensure meaningful responses to disease that respond to individuals' position on their illness journey. Such approaches have also been used to support counselling interventions for people living with HIV and those affected by breast cancer. We also need to begin to shift our response to disease and illness to be one that moves from disease-centred or acute responses to think about longitudinal support. This requires strengthening of referral pathways and a need to reduce over-medicalisation within systems design. For example, considering the utility of traditional and faith-based systems in supporting the provision of self-care or psychosocial support. But to make these shifts at the micro level, we need to move to think more critically about the macro and meso-level factors that continue to perpetuate inequities within health systems. For social scientists, we may think of these factors as examples of structural violence, where we still see that historical trajectories of colonialism and Western dominance of knowledge production continue to shape the formation of systems that rely heavily on biomedicine, with minimal considerations of local and varied forms of scientific knowledge. Poverty and gendered social norms often shape the meaning of health and illness and are largely ignored in the way we structure responses to many health crises. For example, when we think about mental health, the way this is conceptualized, diagnosed, and managed in many settings globally is rooted in Western classifications and psychiatry, with little adaptation to local idioms of distress and local conceptualizations of mental well-being. The way in which many health systems are resourced leaves them little ability to adapt to move to more pluralistic or longitudinal forms of care when they're shaped by donor priorities that frequently promote chronic verticalization and medicalization. Before I hand over to Abu to share Adama's story that emphasises the realities of syndemic suffering in the informal settlements of Sierra Leone, and to reflect on my own question, I would argue that health systems as they are currently designed need significant adaptation to be fit for purpose. But if we can come together within LSTM across diseases and disciplines to change the culture of health systems that moves beyond the biomedical model of the world, we could shape a very different future for health equity over the next 125 years.
Thank you very much, Laura, for your critical reflection on the concept of syndemics. There are two critical points I need to draw from this. First, the complexity of the layers of vulnerabilities faced by people living with diseases of poverty. And secondly, how we envision the health system to respond to the needs of people who face disease of poverty, which are often underpinned by inequalities and social exclusion. So using this broad framing, I'll just share the story of Adama, who lives with a 63-year-old woman who lives with comorbidities of diabetes, depression, and hypertensive conditions in informal settlements in Freetown. Like many people facing syndemic conditions, Adama lives in a marginalized urban setting in Freetown, and she faces extreme poverty, isolation, childlessness, and widowhood. And often, people living with syndemic conditions are likely to face stigma and isolation. So from early on, Adama was refused or denied formal education, which represents or reflects the patriarchal systems in which a lot of these people live in. And so this one has impacted her social and financial mobility and limited her chances of responding to health shock. She lives in a housing condition that is built with shacks and corrugated roofs, and these kinds of housings are exposed to different kinds of vulnerabilities, like extreme weather conditions, rodents, and disaster risks. As a result of the health-seeking challenges in the Sierra Leone health system, Adama's health-seeking journey has often prioritized informal healthcare seeking, and so this one impacted the late diagnosis of her comorbidities. And as a result of that, it led to different forms of complications. And so this reflects the challenges within the health system in Sierra Leone, which shows that there is limited prioritization of NCD conditions within the health system, which informs how people seek care from informal providers. So in summary, the story of Adama reflects patriarchal norms within the society. It reflects structural violence in which people are neglected and removed from their realities and positions. It calls for action to respond to the needs of people living with syndemic conditions in a creative way. And this action refers that it should go beyond biomedical considerations. I will end by saying that there are thousands, if not millions, of Adamas living across the globe who are deprived of health services. This means that the health system should respond creatively to the needs of people living in vulnerabilities and syndemic conditions. Thank you.
Thank you very much, Laura and Abu, for setting up the syndemic framing and illustrating it through Adama's story. So we're moving on now. Please keep your questions, because we'll have them at the end. And we have Bachera Aktar, who is the Assistant Director for the Centre of Sexual, Gender and Reproductive Health at the James P. Grant School of Public Health in Dhaka. She's joining us online from Tokyo. She's just been leading on the Emerging Voices for Global Health programme as part of Health Systems Global, which some of our LSTM colleagues were privileged to join. And she is co-presenting with Rosalind Steege, who is a career track lecturer here at LSTM. So welcome, Bachera. Any technological luck here? Yeah, please unmute, Bachera. Bachera, please unmute. Are you? We still can't hear her. I've asked her to unmute. Yeah. We did a check earlier. It was all beautiful and smooth. Oh, we can hear her now. Yay! Hurrah! Welcome, Bachera. Please start again.
Okay, thank you. Thank you so much, Ali. I hope the slides are already on. Yes, next slide, please. Next slide, please. Next, yes, thank you so much. So Laura and Abu have talked about the micro level factors. Now myself and Rosie will talk about the macro and meso level factors. So yeah, next slide, please. We will show a very short video as an extract from a larger frame that we have developed, produced in the ARISE project in Bangladesh. And today I will provide an example from the ARISE project. The ARISE, many of you may know that it was a 5-year-long project. It was a participatory action research, and we conducted the research in Bangladesh, India, Sierra Leone, and Kenya. Today I will share example from Bangladesh. Could you please play the video, please?
Slum settlements tend to be built on vacant government or private land. Many slum settlements are built on polluted spaces, exposing residents to industrial wastes and all sorts of horrendous conditions.
ভিতরে একটা ভয় আছে কোন সময় সরকার আইসা বইলা দেয় যে কালকে আপনাদের এখান থেকে চলে যেতে উচ্ছেদ করা হইব তখন আমরা এই বাল বাচ্চা নিয়ে কোথায় যাব
Sounds like the most basic amenities like water and electric supply.
বিদ্যুতের লাইন আমাদেরকে দেন আমরা যে বিদ্যুৎ ব্যবহার করি সেটা অবৈধভাবে কারণ ওয়াসা আমাদের ভিতরে লাইন দিবে না 8 টাকার পানি আমরা খাই এখন 35 টাকা দিয়া
এখানে ওই যে আমাদের এনজিও পানি লাইনটা দিছে না অনেকের ঘরে ঘরে কিন্তু ড্রেন করে দেন এটা আমাদের একটু সমস্যা হইতেছে তাই জন্য
which ultimately affect their health and well-being.
প্রতিষ্ঠা 26টা ফ্যামিলি নিয়ে একটা বাথরুম হচ্ছে
এই যে টয়লেটে আসলে আমাদের মহিলাদের জন্য অনেক সমস্যা অনেক সময় মেয়েরা আসতে চায় না বদনি হাতে
Furthermore, the slum dwellers lack various important fundamental rights, such as provision to healthcare services.
রাস্তা একখান দিয়ে ভাঙ্গা আমাদের একটা রোগী যদি রিস্কা দিয়ে নিতে যায় তখন রিস্কা জক্কর রোগী আরো অসুস্থ হয়ে যায়
প্রথম অসুখ বিষয় হলে কবিরাজের কাছে আসে তারা তাবিজ দেয়
3,000-4,000 টাকা জোগাড় করা বড় কষ্ট তো কাজে কি করি হাতুড়ি মার্কা ডাক্তারের কাছে যাই ওই ব্যথার ট্যাবলেট এমনি কয়ে দেয় দুইটা করে আইনা খাইলে কিছুক্ষণ একটু ভালো থাকে কিন্তু পরক্ষণে সেটা খারাপে পরিণত বেশি হয়
These unfortunate people remain vulnerable to various forms of violence.
Okay, so Bachera, back to you on structural inequities within socio-political ecosystems. Is she there, colleagues? Okay, so Bachera.
I'm here, Sally. Okay. Can you hear me now?
Yes. So please go ahead with this slide. Yeah.
Yes. So from the film, you saw that how the living conditions, the overall built environment created the multi layers of inequities and vulnerabilities for the people living in informal urban settlements. So the health and well-being of residents of informal urban settlements are shaped by complex intersections of multiple factors interacting dynamically to perpetuate the inequities and challenges. So, for example, the factors are like macro-level factors like the power relations, unequal power relation dynamics among government, service providers, elites, politicians, and also communities that influence the allocation of resources and services within the settlements, often being deprioritized from the urban planning, and that create another layers of marginalizations. And the lack of formal recognitions of informal settlements in the policy framework also leads to neglect in urban planning, resulting in inadequate resource allocations and service provisions like healthcare, sanitation, and housing, etc. The systematic discriminations embedded in the policies and the government practices also create another force residents into the precarious living conditions because they can't afford proper housing in the formal settlements. And also the other miserable factors like the gatekeepers at the community levels and the intermediaries who control people's access to services and resources. And also the residents are heavily relied on the informal social networks for their survival, including shared resources and informal support systems. And also the intersections and interplay between these macro and measurable factors also create a web of inequities. And the built environment is the key mediator shaped by this both macro and measurable factors, and urban planning, decision-making influenced by the systematic inequities often exclude these informal settlement residents from access to services which exacerbate their health risk. So these intersections between these levels are highlighted. It's important to understand and recognize to make systemic changes, which is essential for improving the health and well-being of the residents. So now I will hand over to Rosalind Steege, who will provide another example from a global context. Over to you, Rosie.
Thank you, Bachera. So I'm Rosalind Steege, and I'm involved as an equity lead for the Gear Up consortium, which aims to mainstream gender and equity through the Fleming Fund's portfolio of antimicrobial resistance surveillance data, or AMR. So I would like to use the example of AMR to highlight the importance of having an intersectional and biosocial approach to support equitable healthcare. Now, we know that the burden of AMR is not equal, globally, but also within contexts, as it is driven and shaped by structural inequities. Patrick illustrated really well yesterday that AMR is a quintessential One Health issue. So that considers health to be complex and composed not only of humans, but of all the other elements in our ecosystems. It highlights the interconnectedness of humans, animals, and the environment. In doing so, it rejects a reductionist approach, removes binaries, and there is therefore significant overlap between intersectional and feminist theory. So what I'm arguing today is that an intersectional lens is really critical to address AMR and the other pressing health inequities that we face. So, AMR intersects with issues of environmental racism with regards to poor living conditions for many globally, such as those experiencing urban informality, who face crowded environments, poor access to water and sanitation, and live and work in close proximity to animals, aquatic life, and wastewater, as illustrated on the slide. And we heard yesterday a lot about the polycrises. So these are also intersecting with other factors prevalent today, such as rapid urbanization, as illustrated, overburdened food systems, environmental degradation, microplastics, climate change, and conflict, which results in contamination from heavy metals, which can drive AMR, the establishment of refugee camps, which create the conditions for it to thrive, and disruption to healthcare systems. So in Gear Up, we've been working on this conceptual model led by my colleague Katie Davis. And what this serves to show is just to highlight the biomedical dominance focused on surveillance data at a facility level. And while I want to celebrate the amazing work that is being done to support this surveillance, what we need to recognize is that infrastructure has much more impact on healthcare than hospitals. And this current biomedical model fails to adequately address the structural inequities that are shaping, as you saw in the video, whether someone can even access a facility or healthcare. They shape the exposure, the susceptibility, and the experiences, including stigma, of AMR. And so we're trying to uncover some of that through Gear Up using an intersectional lens. And this approach also doesn't value, I'll just go back, sorry. This approach also doesn't value the agency or the knowledge of the communities that AMR most affects. And this is really critical, this knowledge is really critical because AMR has been successfully embodied by indigenous communities for centuries. So it's also an issue of epistemic injustice, which is exacerbated by short-term funding cycles that impose power imbalances and knowledge hierarchies. So what do we need to do to address intersecting inequities in a changing world? Well, we need to support a knowledge shift towards truly transdisciplinary, biosocial, anti-colonial and intersectional approaches that recognise these structural inequities. And this means reflecting on our own positionalities, questioning our assumptions, and engaging with critical social science work such as ethics, safeguarding, and the nature of rights. And this collaborative approach is really, really essential, but we should also expand our collaborations. And we need to recognise that there are other types of scientific knowledge and value community and indigenous knowledge through co-design and participation to advance both social and environmental justice. Thank you.
Thank you very much to Bachera and Rosie for framing the issues from an intersectional perspective, linking also to syndemics, and looking at health and well-being and AMR in urban settings. So next up, we have another pair. We have Dr Bintu Mansaray, who set up the Institute for Gender and Children's Health Research in Sierra Leone. She's currently a public health specialist registrar in Oxford. I'm also delighted to say she's our alumni, did her master's and her DTM&H with us. And she's co-presenting with Rosalind McCollum, who is a senior research associate in the MIND team that Laura explained earlier. So welcome, Bintu and Rosie. You have 10 minutes.
Hello, good morning, everyone. I'm really delighted to be here. So I'm Bintu. I am with IGCHR, Institute of Gender and Children's Health Research in Sierra Leone, and I'm currently with Oxford for a few years. And I'll be talking to you today with Rosie. Oh, I see Dr. Lalu. He was my tutor when I was at LSTM. So using our framework, we're concentrating on the BNC section, looking at how conditions experienced by our participants and their social networks, as social scientists, this speaks to us, and how do we shape these responses. So the first thing we're talking about is ethics and safeguarding, as that was the pillars of our work that we did, and Rosie's going to start us with that.
Thanks, Bintu. So running throughout both the studies that Bintu and myself work on, so Bintu works on Arise and I'm working on Redress. So running through both of those studies is a strong emphasis on ethics and safeguarding. And this starts with the conceptualization and then continues on throughout the studies, cross-cutting across other areas that we're going to speak to later on today. Within both studies, there were clear procedures established in order to help promote a safeguarding culture. This included appointing safeguarding focal persons and holding a number of different safeguarding sessions within the community. And while there's a number of common principles to be adhered to across all studies relating to safeguarding and ethics, we also thought to really seek to try and unpack what was unique relating to the participants, the context, the methods, and the data collection tools that we were working with within the studies, and arising from that then to identify risks and mitigating strategies. As an example, within Redress, our study worked with persons affected by skin NTDs, and we were seeking to strengthen the identification of people with possible mental health conditions. This meant we were asking questions to screen for those mental health conditions. We therefore tailored our safeguarding discussions to consider this, ensuring that referral pathways were in place and that researchers were aware when they needed to actually refer someone onwards for additional mental health support. We also thought about the methods that we were working with, such as photo voice, a participatory method where participants take photographs and analyse their photographs together. This can raise a number of unique ethical issues, and these were discussed together with those involved, including issues such as taking consent and ensuring that photos that were taken truly represented the situation. So over the course of our discussion, we're going to make more of a discussion between the two of us, speaking about issues which were common to both of Arise and Redress. So, Bintu, to start us off, please can you tell us a little bit more about identifying who the key communities to engage with within studies are?
Thank you. So when we started, in Arise, we were looking at the health and well-being of people living in informal settlements. And the first thing comes to mind is like, yes, we need the community leaders, we need people who work in informal settlements, who live in informal settlements. We want the stakeholders. And then as we started designing the tools, we realized the marginalizations, that even though everyone lives in informal settlements, there were levels, there were classes to this, and how do we get these marginalized groups on board? And we saw people like sex workers, people living with disabilities, even women who are single, who are unmarried, widows. They occupy different strata in the communities, and we had to bring all of those people on board. Looking at health and well-being, obviously the health facilities, the health workers, and then that included who the communities seek healthcare from. And these are traditional healers, these are pharmacists, versus some communities do not even have health facilities within them. It's about doing this mapping and asking communities, asking the people who you're working with, snowballing basically, and then you realize who those key people are. And in redress as well, you considered people who are living with these neglected community skin conditions and where they seek health facilities. Additionally, we started to build these relationships for their stronger collaboration with the health system, encouraging earlier referrals for neglected tropical diseases, building pathways between communities and their leaders and where they can seek health care. So next, so working with communities is about realizing where does the power lie, who holds the power, and who communities think hold the power. And this was such a learning point for us. In Arise, we did Venn diagramming, social mapping, and in Redress, a power cube analysis was done. So, Rosie, do you want to walk us through some of the things that came out of this?
Sure, thanks. So participatory methods and approaches can be valuable in helping to understand local power dynamics. And within Redress, as Bintu mentioned, they worked with Venn diagrams to understand this fully. In Redress, we sought to engage and to use a power cube analysis. So we found that Gaventa's Power Cube was particularly helpful in helping us to think through the levels, the spaces, and the forms of power that can influence a person or a community's engagement within the research study. By thinking through the barriers that certain communities might face when engaging, meant that we were able to help to try and identify potential solutions to overcome this. So within Redress, this took the form of using different participatory methods, especially among people with limited literacy, involving multiple representatives of certain communities within meetings rather than a single token invitee, and creating opportunities for small group discussion. So, Bintu, please can you tell us a little bit more about the role of creativity in developing a community engagement and involvement plan?
Yeah, so briefly, I'll just talk about Arise and what we did. One powerful thing that we did was called the Power of Light, which when we got Leo, who is an artist here in Liverpool, to go to Sierra Leone and work with communities, to work with artists in communities. Because when you think about informal settlements, you don't think about art. And what we wanted was to showcase the beauty that is present in all of the spaces. And the Power of Light was something very beautiful. It not only showed art, but it showed us what communities recognize as the importance of light that we take for granted. And we saw what light means for them in accessing, say, wash facilities, in accessing education, and just security and safety. So working with communities to develop these creative ways of research, art-based methods, was really insightful for us. And Rosie, so we're talking about community engagement, working with communities. In Arise, by the end of 2023, we've held over 90 community engagements, basically meetings with communities. So what do you think about investing in community engagement in research?
Thanks, Bintu. So central to Arise and Redress was the role that was played by co-researchers who were persons affected by an NTD in Redress and community members in Arise. And so the co-research involved in the study played really vital roles in helping to shape the studies. So they took part in trainings, they took part in data collection, in analysis. They also helped to shape and to guide workshops that were held to help in order to develop interventions. And alongside that, they also shared findings of the study, both nationally and also internationally. For both Arise and Redress, the study took place over a number of years, and this longer duration of the study really provided an opportunity to be able to invest within these co-researchers, to build their skills and their capacities to take on increasing responsibilities over time. But this, as Bintu mentioned, this needed adequate budget to have been set aside in order to invest within them and in order to mentor them over time to develop their skills to take on these increasing responsibilities. And now, since the study, co-researchers have a valuable skill set, which includes a strong understanding of safeguarding issues within their communities, as well as being able to advocate for them, for themselves and for their communities. So, Bintu, please can you tell me a little bit more about the role of reflective practice within research?
So, routinely assessing our practices, being ready for change. Well, we had no choice. We had the theory of change with Arise, and then COVID-19 came. We started in 2019, and COVID just threw a curveball. And it really puts to the test what we mean about being flexible. And we had to work with communities. Their needs changed, what they wanted changed, and we had to make sure we changed with them. And this was the premise for something we call the Responsive Fund, which was very successful. I personally feel, as a local researcher at the time, it was working with communities, asking them what we need, what do you need, and what can we do? We all know that research can be very extractive in marginalized communities. And with Arise, we wanted to give a little bit back. So how can we help you? And it's only by asking communities and working with them that we can make this happen. So in Arise, we have co-researchers doing blogs. We had regular sessions with them. We had meetings with community leaders, showcasing our work, talking about what we've done and where do we want to go next, and how do we do that? And it was something I take forward in everything I do now. Like, Arise has been a benchmark of how research should be done, and this is one of those things, actually working with communities and constantly going through what you've done and how you can make it better. And during our midterm review, we worked with stakeholders across Arise and Redress, and this really helped us to get to the end of Arise that we're in now. And so we've talked about, we're at the end of Arise now, and all of these projects are coming to an end. So what do you think about sustainability? Not just leaving the communities as we met them, hopefully ensuring that the work we've started continues over time.
Thanks, Bintu. So, lastly, in both studies, we've seen how community engagement has led to the creation of structures which are continuing beyond the research project. So within Arise, the District COVID-19 Response Centre, or also known as DICOVERC, which was set up, has been merged within the National Public Health Agency for Sierra Leone. Meanwhile, in Liberia, changing attitudes towards the engagement of persons affected by skin NTDs now means that people affected are routinely involved within Ministry of Health decision-making meetings. Finally, people affected by skin NTDs have mobilised to establish and register as a network called the Network for People Affected by NTDs in Liberia, also known as Nepa NTD. Finally, we'd just like to thank the co-researchers and other key communities, such as community health workers, informal providers, and Ministry of Health and community members who have shaped and guided these studies. And thank you for listening.
Thank you.
Thank you so much, Bintu and Rosie, for so ably synthesising learning across different projects around community engagement, ethics, safeguarding, and that all-important question of sustainability. One more presentation. Please keep your questions. So I'd now like to invite Shahreen Chowdhury, who's a research associate here at Liverpool School of Tropical Medicine, who is joined in video form, I'm sure the technology will be seamless, by our colleague Emmanuel Zaizay, who Shahreen will introduce. Welcome.
Hello everyone, and thank you for having us today. And building on Rosie and Bintu's presentation, we'll be focusing on Section B of that syndemic framework, really specifically on lived experience and how this is really central in our work. I'll be presenting with Emmanuel Zaizay, as Sally said, patient advocate, co-researcher, and so much more. And although he unfortunately couldn't join us today, he has pre-recorded online. And Emmanuel was actually also illustrated here. And in this quote, he really speaks to the value of patient advocacy. I share my story with other people affected so they feel convinced and encouraged to seek care. So why does lived experience matter? Lived experience and patient advocates bring unique insights into health system strengthening, which traditional research methods and often biomedical dominance can often overlook. And this presentation will explore how patient advocates and co-researchers with lived experience can set research priorities that are inclusive and impactful. And we will use case studies from Nigeria, Liberia, Bangladesh, and the DRC to illustrate this. But how do we embed lived experience in research in ways that are meaningful and not tokenistic? Well, we need to move away from consultation to co-production. And one way is working with co-researchers. And this is a term that we often use quite a lot in social science research. But what does it mean? Well, it can involve people and individuals from affected communities who actually play an active role in the research process. And this can be from, setting the research priorities, research design, but also data collection, analysis, and also co-design of interventions. And co-researchers play a key part in ensuring the relevance of the research. And they often include particularly marginalised groups who have been historically stigmatised and neglected. For example, people with NTDs or disabilities. And these are some examples of studies where we have worked with these groups. I will now pass over to Emmanuel through video, and hopefully it will work, who will share his experience of how he's used his lived experience as a co-researcher within the redress study.
Hello, everyone. I'm Emmanuel Zaizay from Lofa County. I am a person affected with Berry ulcer. I was diagnosed with it 2019, and then I recovered 2020. In 2020, I was also recruited by Attorney Saleh, the individual focus person, on the redress project, wherein I was trained to do photo for us and also do group discussion. And also, as part of my role in the redress, I also serve as co-researcher on the redress project, and also serve as a co-chair for the community laboratory board that was structured of 15 members in different positions in the county. And also, I was involved with data collections and also with data analysis, wherein I was also used to lead the peer support group in the 3 counties in Liberia, Lofa, Grand Jide, and Margibi. And I also serve as a campaign head, wherein I was opportune and supported by the Redress Project to do radio awareness and also go into the market with posters telling them the stigma on human being. And also I was supported again by Redress, wherein I was sponsored to attend the internet conference where I was able to meet other NGOs and other partners around the world as persons affected. And also we all know that projects comes and ends, and then our prayer was what can be left of us here as persons affected organizations. So as God we have it, we're able to Redress, along with us, we're able to establish a network of persons affected with entities in Liberia currently that is assisting. And also I was also involved with intervention design, wherein as you see some road wherein I was trained as a peer support lead, wherein we were involved with making soap as a group that we use to sustain ourselves, that was supported with seed funding. And also, I just want to use this time to tell all NGOs, all organizations, all projects, that whenever you want to have a project of such, it is advisable to involve persons affected with these conditions entities. That will help to make your work easier, because persons affected themselves are the ones in the conditions. So using persons affected on a research study, it is very important, as Redress have done. So I want to be grateful to Redress for helping us here in Liberia to see how entities can be eliminated. Thanks.
So as you can see, Emmanuel is a great spokesman for Redress, but he spoke about intervention design, and we've actually used and actually worked with co-researchers with lived experience in projects across not only Liberia, but Nigeria and the DRC, where co-researchers with their lived experience of NTDs have actually led and designed peer support groups, many of which are still continuing today after the project's end. I also want to talk about, to make co-production successful, we really need to prioritise accessibility. And these photos are from a study where we worked with people with lived experience of psychosocial disability and caregivers as research partners in Bangladesh and Liberia. And what we found was that peer-to-peer research can really promote trust in the research process, but this also requires time, training, fair remuneration, and often creativity, which has really been spoken about by Rosie and Bintu as well. In this study, we used creative participatory methods. And just to say, this was particularly powerful, especially as images can resonate beyond culture and language. And often this can be a way where people can direct how they want their stories to be told, and they can be the storytellers of their own narratives. Another example of using creative methods was in the study in Nigeria, whereby co-researchers shared their findings in a dissemination meeting with Ministry of Health officials and national stakeholders through cartoons. And this was the first time that many of these co-researchers were ever in a space with these stakeholders and even had the chance to actually share their stories firsthand. And it really helped manage those power dynamics as it served as a way to centre lived experience. And many stakeholders were moved by the experiences. And this was in 2019 when the focus of NTDs was really on prevention, but not so much on management. And so the psychosocial aspects of living with an NTD was really highlighted. And just to say that these stories really humanise the condition, fostering empathy and addressing stigma. And this highlights that innovation in research is also about finding accessible, human-centred ways to communicate. We often talk about people having a seat at the table, but that seat needs to be accessible for persons with lived experiences to meaningfully participate. And here is an example of a dissemination meeting within Redress, where we brought together diverse stakeholders, including peer advocates, traditional healers, and people with varying levels of literacy. And this was really to create a space where all forms of knowledge and perspectives are valued, as has been mentioned by the previous presentations. We moved away from PowerPoints to visual aids, storytelling, and smaller group discussions. And a theme in LSTM's 1 to 5 anniversary is really equitable partnerships. And I'd just like to stress our multi-way capacity strengthening, because we all learn a lot from each other and we have a lot to learn from lived experience. And this also fosters transparency and ownership in the research process. I'd now like to share another video from another co-researcher, Isa, in Nigeria, who speaks on this.
So kaga ya taimaka. To information din da wanga training da muka yi gaskiya taimaka. Ya shiga cikin al'umma da yawa, ya shiga ainihin inda ake so. Ba kamar da yadda iyaka sai dai a shirya mana abu daga nan ba. A ce daga nan Abuja ko daga state a ce mana ga abin da zamu yi. To wanga abun mu ne ke da ownership nashi. Abin ya taimaka mu wurin haka nan. Ya shiga can.
And so Isa there spoke about how this process created spaces for empowerment, ownership, and really honouring local knowledge. And so final reflections, We often use the disability justice slogan, nothing about us without us. But to ensure that this isn't just an empty slogan, this requires working with patient advocates, not just as participants, but as partners and leaders in driving change as experts of their own lives. Our learnings highlight that transformative power of shared ownership in health research can really foster more sustainable solutions. But co-production is a learning journey, and it's crucial that this requires ethical and safeguarding frameworks, financial and logistical support, and of course, accessibility and flexibility, particularly in research and policy spaces. Thank you so much.